Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to this episode of the Doc Podcast. Today, my guest is Dr. Jack Fisher. Dr. Fisher completed his orthodontic training at the Medical College of Georgia in 1982. Since then, he has been in the full-time practice of orthodontics in Kentucky and Tennessee. He has lectured both in the United States and internationally, has published articles in numerous orthodontic journals, and is one of the first in the profession to use temporary anchorage devices and MARPI. Dr. Fisher is presently a faculty member in the orthodontics department at the University of Tennessee, and many of you may know him from the outstanding 2-day cadaver course on the insertion and use of temporary skeletal anchorage devices that he taught for 15 years. He has written several articles on the use of TADs, or TSADs as he calls them, and has recently developed a course on the use of CBCT imaging for the diagnosis and treatment of orthodontic patients. Dr. Fisher is an inventor, educator, pilot, husband, father, grandfather, and all-around great guy who you will learn a ton from listening to. And during today's show, we're going to dive into his personal story, the use of CBCT imaging in orthodontics, the current state of orthodontic education, when we should expand in the absence of crossbite, MARPI, airway in orthodontics, evidence-based practice, and much, much more. So without further ado, let's get on to today's episode with Dr. Jack Fisher. Enjoy the show, everybody. Welcome to the Doc Podcast, Jack.
Well, I'm pleased to be here. I'm honored to be here. It's actually very humbling to be asked on your podcast because I've been very, very impressed with your 105 or 106 episode. And I listen to them all the time when I'm driving back and forth between Nashville and Memphis when I'm not flying. And what you're doing has got to continue. You keep fighting the good fight.
Well, thank you. I promise to do that, and I'm humbled by you saying that because someone of your stature and expertise in this profession who I went and saw years and years ago when I was in upstate New York talking about TADs and how to place TADs or TSADs as you refer to them. Years ago, it's very humbling for me to have someone such as yourself say that about my show. So thank you for so. What in your background would you like the audience to know? If you can take it back as far as you'd like. As I always say, how did you get to be the Dr. Jack Fisher that you are today?
Well, it's humbling for you to give me that kind of recognition because I'm dyslexic and ADD. So I'm in a hurry to come in here backwards. And so even when I'm landing in an airport, I got to be really careful that I'm landing on the right runway, hidden in the wind, because, okay, it's just the way our minds are when you're dyslexic like that. So you learn how to overcome it. But I think I sent you a picture of me when I was 6 years old.
You did.
Standing to my best friend, who's an orthopedic surgeon, and a really good orthopedic surgeon. And he and I both grew up with a mindset of a different skill set for thinking. When we worked with residents, I don't know that they had the same skill set for problem solving that maybe some of our older people do because they're so dependent on electronic things in their hand. But anyway, so if the lawnmower was fixed, I had to fix it. And so he invented an apparatus to doing spine surgery. He was a spine doctor and developed that. And I also developed some stuff for the vertebra. And so I was telling him one time about how I was struggling with skeletal anchorage. And he said, let's invent a screw that we can do that with. That's how I got involved with that. I'll get into a little bit more, but we were standing in that picture. I was a mouth breather at an early age. I know it was due to, the genetic factor and the environmental factor as far as sleep disorder breathing and breathing problems is very complicated. It's more complicated sometimes than we want to make it sound. But I could not breathe through my nose due to allergies. So I probably inherited the allergies. Then the environmental part plays a role in that. And so then I grew a longer face, narrow nerves, could not breathe through my nose. And I often wonder if that contributed to my attention deficit disorder. I couldn't say my ABC, so I was like in the 4th or 5th grade. I couldn't spell my name. And so for me to be where I am today as an orthodontist, I'm not so sure I can make it today. When I work with the residents, they're much brighter than me, and they teach me far more than I teach them.
I feel the same way when I teach them. Yeah.
And so I'm sure we'll get in a little bit more. But I was in that little small town in Kentucky and had just become a Christian at age 15. And I would pray at night, show me something that I can do to help people. And so I was sitting in this dentist office and I was teaching his kids to play basketball because the only thing I really cared about in school was basketball and maybe outdoor stuff. Well, he made an agreement. I'll take you fishing and hunting if you'll teach my kids to play basketball. So I had a key to the gym. So I was in there all the time. And so I said, yeah, I'll do that. So this girl walked into his office that was missing a front tooth, and she obviously knew me, and she wouldn't smile. She wouldn't look. I think he gave her a flipper. And she walked out there and smiled at me. And I go, okay, God, that's what I'm supposed to do. I'm going to be a dentist. And so that's when I made the decision. And I just think with my disabilities that I have, probably due to the sleep disorder breathing that I developed at birth, that I really had to work really hard to actually get into dental school. I was playing college basketball. And boy, when you're at that level of sports, and you're a pre-dent or a pre-med, it's almost impossible.
Tough.
So it's a miracle that I got in dental school. And I was so afraid that I wasn't sharp enough to get through dental school. I ended up graduating pretty high in my class and then went on and did my residency in Augusta, Georgia. The reason I went to Augusta was because of a gentleman named Gene Williamson. And in the early 80s, he was a TMJ. He was a prosthodontist before he became an orthodontist. So he was dual trained in that realm. So he always called himself a nathologist. And so all of the radiographs that we took on our patients in my residency, and I went there because I was interested in tempomandibular joint. I mean, we were not taught anything about airway. But all the radiographs and records that we took were mounted models, of course, and a PA radiograph, a submental vertex radiograph, and a lateral, what you would call a Ceph. I was taught to call that a sagittal view, a coronal view, even then. So even then, I was taught to diagnose in 3 planes of space. And so that's all I knew. And so it was later that I realized that not all people were taught like that. And so anyway, so it was a natural progression for me to get into 3D imaging. But in doing so, one of the biggest influencer in my life was Dr. Sleepman Arsdale. He would come to our residency program from the University of Penn, and he showed us how to uncover canines and apical reposition of flap. And even back then, he was doing, instead of doing pull flaps on the lingual, he was showing us how to cut a window and expose. So I've always exposed my own canines. And but he told me in 1994, he said, Jack, we need to figure out how to do expansion skeletally and not dentally. He said, because all we're doing is tipping teeth out. Yeah, you get a little separation. That relapses often. But he said, because he was a periodontist. He's a dual-trained periodontist orthodontist. And so was Mariana Evans and those people. And he challenged me. He said, you need to figure out how to do this skeletally. I said, okay. So that's when I sat down with my friend and said, let's develop a screw where I can push on the maxilla, the bone, and not the teeth. So that's when I developed that TSAD system or TAD system, whatever you want to call them. And that was a real venture. I'll tell you that venture, pioneers get killed. Settlers make millions. And so I never, it's a long story. It's a whole nother story about that whole venture. But GAC put me speaking all over the place. Yeah,
that's when I saw you was through GAC.
Yeah, and so they sent me to probably out of the 73 residency programs, I went to over half of them, and there's some international and stuff like that, and they would pay me to speak, and that was so much. If you're not careful and you become a KOL, you get an ego developed into that. And so my son and I started the cadaver course where I would have cadaver heads, and we did that for 15 or 16 years until COVID, and got to the point where we would only let residents come because I got so frustrating working with orthodontists, and they would come in and say, "Now, do I have to give an injection?" And I'm going, "Okay, doctor, what dental surgery?"
Right, you've done this before, right?
Yeah. So anyway, it was very frustrating to me. So we kind of quit having orthodontists come, and I just focused on, and I really love education. And then I was on faculty at NYU for a while. I was on faculty at Louisville. I was on faculty at Vanderbilt, and now I'm on faculty at the University of Memphis, or the Memphis program. And I had 2 or 3 practices at the time doing all that. And one time my son called me. He said, "Dad, you're a prostitute." And I said, "What do you mean?" And he goes, "Well, you use some brackets that company recommend that they want you to use that you don't even really like. So you get the money." And plus, I was trying to sell screws and then lecture. It became very uncomfortable for me, so I just quit. And so, I realized that probably wasn't me. And so I quit doing it. I kept doing the course and had people come, but I didn't like lecturing or being a KOL. And then playing Mecca, I wanted to maybe the KOL. I didn't really want to do that either. So, but that was my venture. But Dr. Van Arsdale influenced me in a very positive way. And I'm not sure if it was he or myself that did the very first marketing that was ever done in this country. But I can't remember if he came up with the idea of placing 4 screws in the palate. So I developed a screw, had a huge platform to push on the bone, on the cortical bone, because KLS Martin had a system out. It was $5,000 for the screw, and you really need an oral surgeon to put somebody to sleep to put that device in.
Wow.
I did 2 or 3 of them because UT would do them for me and charge my patient $1,000 to say, okay. Boy, they worked. And so I felt like the screw needed a platform to put. So I would put 4 screws in the palate. And if you don't know how to read the CBCT, you're going to run a big risk of hitting roots. And so I never patented that screw, but I could legally do it and get my son. My son is a machinist, that he would machine them for me, and I could write a prescription that's legal. I could put them out on a patient, but I just couldn't market them. And after all I'd been through, I didn't want to do another patent, do all that stuff. And so I did literally hundreds of those. I knew they worked, and I could see on the CBCT. And when I would lecture early on, I would say to doctors, "You know what? You don't really need 3D imaging to do these screws. Just look at your Panorex and stick the screws in there." But keep in mind, I was trying to sell screws. And so, but every time I would do a MARPI on a patient, I sent them down the street to a general dentist who had a CBCT. She had a plan Mecca. And I would pay for those. And I started looking at the coronal views of my screws and what was happening to the maxilla, what was happening to the teeth. And I started seeing some teeth I was moving out of bone. And I was like, oh my gosh. And so then I totally changed my opinion about 3D imaging. And so I even had one orthodontist in the Northeast that said to me, he says, I bought an iCat, and when you told me that, I sent it back.
Oh, jeez.
I said, I feel bad about it. I've always felt about that. And so, but anyway, that's kind of how I got involved in CBCTs, was doing MARPI. And but the people he influenced, Dr. Van Arsdale, Mariana Evans, myself, Dr. Bacow. I didn't know this, but Dr. Yoon, Audrey Yoon went there before she, I think, ever went to a residency and spent a summer there. And so I'm sure he had some influence over her. So, and I started looking at the people who started doing MARPIs. It was all his influence.
Wow.
But I think his goal was periodontally, to leave teeth in bone.
Yeah.
And so when I first started doing CBCTs, that was obviously my goal. Okay.
Right.
I mean, even the ABO, the American Board of Orthodontics, will say the teeth should be in bone.
Right.
Until they don't really look.
Right.
And, and so, and I saw how many teeth I was moving out of bone. Now, the teeth don't fall out necessarily, but they're certainly not healthy. Right. And Dr. Van Arsdale was seeing his patients come back 40 years later that needed grafts because he tipped them out of the bone, and then they got recession. And so, because he's a periodontist, so they come back to him. Orthodontist, I don't think we ever see that.
No, probably not.
Have you heard the story about the 3 campers in the desert?
No.
And they were hungry. It was nighttime. They turned their lantern on, and all they had was 3 apples. So they cut the first apple open, and there's a big worm in it. So they threw it away. They cut the second apple open, another big worm. They threw it away. The guy turned out the lantern. He goes, "What are you doing?" He goes, "I'm hungry." I don't really want to know.
Yep.
And so when people say, "Should I get a CBCT?" I go, "Look, if you really want to know what you're doing, you probably don't need one. If
Right.
if all you're going to be is a tooth mover,
Yep.
like the ABO pretty much is,
Yep.
position the crowns where they're in the perfect class 1,
Yep.
which, by the way, show me the research where that matters.
Exactly.
Okay, you probably don't need one. And I'm not saying that you're a bad orthodontist because you don't look, and maybe you're hungry enough that you need to pay the bills.
Yep.
Because it's a long, long road of education. And the education, my dad always said, education is something that happened to you that you wish the heck had happened to somebody else. That's experience. And so I got a lot of experience doing those and looking at that. And now, I've done CBCT on every patient I have since 2009, 10.
Wow.
And and I'm still learning.
Agreed. I feel the same exact way when I look at images. It's a learning process. And I started taking them on every single patient in early 2014. And I still can't believe how many orthodontic residency programs are not only not taking 3D images, but opposed to it and do exactly what you said. They only take it when they see something on 2D. That would almost be analogous to, in your example, seeing the worm and then turning the light out and biting that same apple because it's like, well, I'm hungry. I saw the worm, but now I want to try to eat. I don't understand it. And I'd love to hear your thoughts as someone who's been in this profession for a number of decades, who knows a lot of people, has been teaching. You've been in private practice and academia for a long time. Do you think there's anything else beside not wanting to see it? Because I agree with you. I think that's a huge thing, is we almost don't want to know what we don't know. We think, well, geez, maybe I'm tipping these teeth in a place I shouldn't, but if I take a 3D and a cone beam, I'm going to know it. And I don't want to know that. It's easier to, again, turn the light off. Besides that, I think of cost, right? It is expensive, more expensive. Their prices are coming down, but they are more expensive than a 2D machine. It is more expensive to have the software programs to read them and the storage. So fine. I mean, we can make a case for it's well worth it, obviously, but just thinking of the obstacles people would say. They used to say radiation dosage. Now that's irrelevant because those dosages have come down so much, and you can get low dose machines and take 2D for less radiation than 3D. But even if it's not a low dose machine, you're talking an infinitesimal amount of difference of cumulative dose radiation. So what is the psychology behind our colleagues refusing to do this? And the last thing I'll say on that is when I mention the A word or airway and say, but you can see so much more. You can see this patient's airway. And they say, that's not our place, or that's not diagnostic, or that's not the gold standard. And I just shake my head, Jack, and think they're just missing the forest for the trees in all of this.
Okay, you brought up a lot of topics in that. Mm-hmm. The first topic that you brought up, I heard you say the word why. Okay. So you go to your residency program, and at 1 o'clock every time we're there, they'll present a case. And everybody goes around the room, and the first question, well, how would you treat it? How would you treat it? Their first question is how. My question to them is, that's the wrong question. Why are we treating it? Because if you just treat the how, we all know how to straighten teeth. I mean, how many different ways can you torque a tooth? How many different ways can you rotate a tooth? We could all debate which is best.
Right.
What is not debatable is diagnosis. We should all be on the same level as diagnosis. I personally cannot understand why orthodontists think the world is flat. Because a patient does not grow in 2 planes of space.
Right.
So let's address a lot there to unpack. First of all, we have a thing called the American Board of Orthodontics, which is needed, very viable in the past. When was the last time you went to Blockbusters?
Oh my, 25 years ago.
Yeah, what happened to Blockbusters? They served a purpose.
Yeah, it's called Netflix.
Okay. They could have Blockbusters could have bought Netflix for $90 million at one time, and they didn't think that was relevant.
Yep, I knew that.
So we're talking about how relevant maybe is one of our organizations, their boards, and I would make the argument that they're no longer relevant.
And for the lay people listening to that who think, oh, wow, but that's a board, just to give a little context to what Jack is saying, they don't, you can't even take a 3D image in there. They won't even, if you take a 3D in your practice, you have to convert it to a 2D Panorex and a 2D Ceph, lateral Ceph, to go and sit for the board exam. And they're not looking at the roots in the bone. They're not looking at all these diagnostic features. Or I would even be willing to say, Jack, they're not looking at the why. Would you agree with that? Yeah,
that's right. And so the thing about the why, if you don't treat the why, or how did this happen, so that we know how to treat it, why is it that like 90% of all orthodontic cases relapse? We don't know the answer to that. I wish I do. But we're told because we expand intercanine width, but it's really funny. Even when you don't expand intercanine width, they still relapse just as much or more. Yeah, and so that. It's very perplexing to me that, and I was told by somebody that's very reliable, he's going to be the future president of the AAO. He's also a chairman of our orthodontic department. We won't talk about what department. And I was having this discussion a few weeks ago with him, and he goes, Jack, I just tell you that it's not on the board's radar to start adopting CBCT.
Wow. Did he give a why? Did he give a why?
No, we're in front of some other residents and that type of thing. I just didn't think it was the time or the place to have that discussion. But if you're going to ask me to be in a residency program for 3 years and go that much in debt, I want to learn more than just how to move teeth. My goodness. Now with AI and the internet, YouTube, they'll show you all 1,000 different ways to torque a tooth.
Right.
I don't need a faculty member. What we have done with our education in orthodontics and residency, we have institutionalized, what was it called when we would go into an orthodontic? I mean, back in the 50s and 40s, you would go into an orthodontic office or to a person that does orthodontics, and you spend 2 years with him, and you were an orthodontist. All we did...
apprenticeship.
So all we did was institutionalize that.
Yeah.
So now you're there 3 years, and you're making good money for the department because... Most orthodontic programs and most oral surgery programs, they float the whole dental school.
Because they're also, correct me if I'm wrong, they're not only getting tuition, they're getting GME money on top of that, correct? The graduate medical education money from the government, which I believe is upwards of $100,000 a resident, I think. Don't quote me on that, but I think.
I used to think it was 100. It's more like 2.
Come on.
So when I was on faculty at Vanderbilt, they were closing the program after we'd been there several years. And that was a private program. Vanderbilt's a private school. But it was a hospital-based program. We were actually based underneath the oral surgery department. And so they were getting $100,000, we thought, from the U.S. government for each residence. They would pay each resident $50,000. Vanderbilt paid the residents. They didn't have to pay to be there. And so that's where their 50 came from. The other 50 went into the general fund of the whole Vanderbilt University. The orthodontic department didn't get it. But we could have kept that department going had we got the full 100 to educate that person. So, it's a real moneymaker for schools to get that funding for those residents. And so I was talking to Lou Shimura because I know you had him on there for a tip.
Yeah, Lou's great. Yeah,
Lou's a really good friend of mine. I think he took my cadaver course and he saw me speak in Las Vegas at one time or something. So we became really good friends. And Lou's a very humble guy.
Yes. And
I called Lou before I came on this podcast. I said, Lou, I need some advice with Dr. DeLuke. I go, I listened to your podcast a couple of times, and you were so humble. and he said, Jack, you know what? If I had that to do over again, I think I would have been stronger. And I said, well, I just don't want to offend people like the board or residency programs and things like that. But he goes, no, he said, you're a 73-year-old. Why do you care? And so my point is, we're going to be like Blockbusters. If the powers to be don't get on board with what's good diagnosis. When's the last time you read a good research in the AJODO, which Dr. Profit was a really good mentor of mine too. And I had developed a technique to close an open bite, and I would sit down with him at AAO for like 6 years in a row. He said we'd talk for an hour, and he would text me and say, "Here's the hotel I'm going to stay in. I want to sit down and talk to you." And so, and that's what I was closing open bites with screws, and so it works, but no orthodontist is going to do it. Just like no orthodontist should put 4 screws in the palate to do Marpy like I was doing them, because they're not trained to do that, and they don't need to go see a lecture, and I'm going to go do that. They just don't need to do it unless they've got the experience and the know-how to do that, but they're not taught in the residency program. And so anyway, the whole system of education, if we're not careful, we're going to ruin ourselves. And we kind of did it to ourselves, because orthodontist means straight teeth. Straight dentist teeth.
Sure.
And when I got out of my residency in 1982, I started my practice. I went and built a building, started practice, a de novo practice, had no patients. But my sign did not say orthodontist. My sign said dentofacial orthopedics.
Even back then. Wow. And that was before they changed the name of the journal too.
That's right. And so, but I felt like that because I was so interested in orthodontic surgery, because in my story, I ended up with orthodontic surgery at age 46 because I had a long vertical growth. I had a narrow maxilla. My intermolar width still only 29 millimeters.
Wow.
And I'm a CPAP. I'm diagnosed with, it's not obstructive. Mine's neurological, but still, who knows? Maybe it wouldn't have been back then if we'd know what we know now.
Right.
But anyway.
Were you going to say, Jack, on the research in the AJODO that, because I've said this before, it'd be interesting if this is where you were going, that we don't see any good research coming out of U.S. ortho programs? Is that where you were?
Another good friend of mine is Barty Nelson. She's the chairman of the Department of Denmark. And I lecture with her a couple times. Our paths crossed.
She's great. I love her literature,
And Dr. Profit also said, out of all of the things that are published in AJODO, only about 1 or 2 articles a year are probably really significant, and so, but we called ourselves orthodontists. So we were the American Association of Orthodontists, and then the American Board of Orthodontists. And I feel like that we should be the American Board of Dental Facial Orthopedists, because I think we're now, even now more than ever, it's the reason it's the most exciting time in history to be in orthodontics, to be a dental facial orthopedist, because now we know how much we're influencing the health of patients.
Can you explain that more? And
Sure.
I agree with you, but I'd love you to go into that.
Okay, so as somebody who was trained as an orthodontist and board certified orthodontist, but I've always felt like I was a dental facial orthopedist, because let me just tell you a little bit about my story and remind me how to get back to where we were. When I got out of my residency, I loved orthodontics surgery. And I went in practice with an oral surgeon in Jackson, Tennessee. He was trained under Dalwick. I scrubbed on more than 100 orthodontic cases of my cases during the years I practiced with him. And I don't know how many plication TMJ patients I scrubbed on. And I would get a surgical assistance fee of maybe $1,500, $2,000 way back then. Heck, a whole osteotomy now doesn't pay a surgeon $1,800.
Wow,
but anyway, so after about 5 years of orthodontic practice, I called Bob Bays, who was the chairman of the ortho department at Baylor. He was at Augusta, where I was, as an oral surgeon. He became chairman there. And I said, Bob, I think I want to be an oral surgeon where I can do my own orthodontics and orthodontics. And I don't know, maybe one other or two other that are trained like that on the planet. And he goes, Jack, if you want to come be an oral surgeon, you're welcome. You're in. Come on. He said, but you're an idiot for doing that because you got to practice. You got 2 children. You got a family. You're talking about changing your whole life for a 5-year residency program. And I said, okay, you're right. So I chose not to do that. But I was knowing that at that time we were helping people straighten out their whole face and their jaws. Now we're realizing, and I think we way overuse the term airway, and I think we should start using the term that we as dental facial orthopedists, we're anatomists first. I can change a person's anatomy. I can change their maxilla up to age, I don't know, Audrey, you just presented at the Marpy Symposium 100 consecutive Marpy cases of age 24 to 64.
Wow.
Out of the 100, 98 of them were successful.
Wow.
Without having SARPI, or surgical assisted rapid palatal expansion. And so we know with Marpy, with the new techniques that come out with 3D printing of the metal, of screws that we're sticking in people's heads that are 17 millimeters long that don't fail. Be honest, the screws I invented and had patented and used, they were little short screws. We were so afraid that because dentists, they just couldn't visualize doing a long screw.
Right.
And so, and we were showing them all just take a Panorex and stick them in between the teeth. And about 80% of those are going to fall out. They're not effective. But somebody had to do all that before we can get to where we are today.
Yep.
And so now we can change people's anatomy. But we know that a person's anatomy is set by age 8. Why would I wait to age 12 or 13 when they're already grown? Now I got to put screws in their head? Okay, right. I don't mind doing that. I do probably two, if not 3 Marpies a week in my practice. All the time. I love doing them. They're fun. And because I see that how I can help somebody not only breathe, but with their teeth and their smile. And I think I keep teeth and bone better. But why would I wait to age 8? Well, and somebody texted me today, well, what age should you see a patient? In my residency, we were on the cleft palate team.
Yeah.
We expanded people's maxilla 2 days after birth.
Thank you. I have said that multiple times to people. When they say there's no evidence for treating these patients younger, I say, have you ever been involved in any cleft craniofacial care? Because once we see that facial dysmorphism and that altered growth and development at a young age, once we recognize it and acknowledge it, then we have no problem going in younger. The problem is we're not recognizing it, and we're just saying, and I'd love to hear your thoughts on this part too, why we just as orthodontists say, well, Jack, Mike, that's great. It's genetics. There's nothing I can do. We don't do that with a patient with a cleft. We acknowledge that, yes, they were genetically born this way, but their environment and the muscle pull and the soft tissue influences are going to have a tremendous influence on this patient's survival, essentially, and their health and well-being and their emotional well-being is on top of that. Why don't we acknowledge that with a patient who doesn't have a labeled disability or syndrome or genetic alteration? What is it about us that is so dogmatic, Jack, that we can't make that connection? Hey everybody, be sure to check out the Doc website where you can get access to tons of great information, including free educational content, access to private one-on-one coaching with me, ADA CERP recognized CE courses, and amazing patient testimonials. Just go to theorthocoach.com. That's theorthocoach.com. And now back to today's episode.
We're not healthcare professionals. We are disease treatment specialists. We are taught if we see a hole in a tooth to restore it. We are taught if somebody has a toothache, that we fix it. And so I think orthodontists, when they get the residency, they're trained, okay, how would you fix a Class 2 Division 2, Dr. Fisher? How do you fix an open bite? It's the wrong question. The question is, why does this 15-year-old have an 18 millimeter open bite? Why do they have that?
And they say genetics. That's what people say. That's what all they say back.
The only thing they can really inherit from that, you can inherit some of it, but I would say it's about 20-80 rule, 20% genetics, 80% environmental. So I have got a presentation I just showed the other day to the residents where I showing them open bites, and so the ones I love to treat, if I can catch them when they're 3, 4, 5 years old, and they're already developing an open bite, and that's so multifactorial. But boy, we can really improve that person's health. Yes. And I don't even like to say airway, but that is such a multidisciplinary approach. And it's not, all I can do is change their anatomy.
I love that.
That's what we do. And we are a major part, and I'm not downsiding. The change in anatomy is important. Yep. But by changing their anatomy and getting them in the right hands of people who treat different disorders that cause their health to deteriorate, we are really treating people's health and improving their health more than we ever have in our careers, and since orthodontics / dental facial orthopedics has been in existence. Now's the best time to learn that. And
I agree.
So if you're going to keep me in a residency program 3 years, I want at least a year of that.
How are you looking at that? What is your why, and what results do you see?
Yeah, I had this long discussion with this Dr. Profit. And he even wrote an article in 1978 that your form follows the function.
Yes, I know the exact article. I have it.
Okay. So so my answer to that is, for somebody, like I told you, I'm not that sharp tech in the box, but I'm full of common sense. Common sense is uncommon. But anyway, when a child is born, why do they have that big hole in the top of their head? Why? Because the brain is growing much faster than the bone. So your shape of your skull is not so much inherited as it is environmental. So if the brain, and maybe you can inherit a larger brain, maybe you can inherit a large tongue, maybe you can inherit a small tongue. I don't think you really inherit how your jaws grow so much. Maybe a class 3, maybe prognatic. And yes, you can inherit a short mandible, no question. But as far as inheriting an open bite, no way. You don't inherit an open bite. So to say what causes the open bite, it could be a tongue tie. It could be a breathing issue. 75% of those kids have big tonsils and adenoids. That eliminates them right off the bat. That's easy to diagnose. It's not hard for me to treat them at age 3, 4, 5, and 6, and 7. It takes a long time for me to diagnose why.
Yeah.
I got to send you to an ENT. I got to send you to a pediatric ENT. I'm going to send you to a myofunctional therapist. I may have to send you to the pediatric dentist because you do have some decays. You're going to lose space and maybe get crowding. So when you start talking about breathing, I really don't consider myself to be an expert in breathing because it is so multifactorial. But I really admire Audrey Yoon for what she's able to do. That young lady is amazing.
She is.
And Dr. Bacow and Mariana Evans, those people, maybe I was a pioneer, and I say pioneers get killed. They really had put all this together. You got to hand them for that. And so it's...
And they've taken their fair share of arrows, unfairly but they have... It's sad to see what a lot of our colleagues have tried to do to those three for speaking the truth and being willing to be pioneers, and I have tremendous respect for them for doing it, and admire that they haven't become jaded and angry, and they still continue to just go about their business and do it professionally. And so I agree with you on the why of that and the normalization of anatomy, which is such a critical part of this. The thing that you said that I want to make sure I underscore a little bit is nothing that you're doing with that child that takes you the most time has to do with the treatment. It has to do with the diagnosis. And that, I think, gets to the core of this problem. That is because we don't see 3, 4, 5, I would venture to say in most residencies, 6, 7, 8-year-old patients with any sort of frequency. We don't know how to look at them. We don't know how to talk to them. I mean, if you're a young resident or a young doc, chances are you may not even have a child that age. So you don't know how to navigate that space. So when we tell our orthodontic colleagues they should be looking at the why and going in earlier to do these diagnostic tests that you're referring to, which again, I completely 110% agree with all of it. It's just so outside of their reality because, as you alluded to before, they have spent hundreds and hundreds of thousands of dollars, even up $1 million+ in student loan debt to get to this point. They've put all their time and energy to learn this, to be the best tooth straighteners. Now they're going to get out and they're going to hear a Mike DeLuca or a Jack Fisher or even an Audrey Yoon or Rebecca Bacow tell them you should be seeing these patients before you were ever taught to try to avoid the very problems that you spent all this money learning to fix. You see where I think it just gets really hard for people to reconcile. Yeah.
And so then they have design research projects to say, are we going to disprove that? And I'm not going to re-mention his name, but we talked about this individual earlier in the thing, and he called our chairman of the department and says, hey, I would treat all these kids for nothing. And we'll show that maybe, doing expanders does not have anything to do with the tonsils and adenoids. So they were going to disprove. It wasn't to try to figure out how can we help people. It wasn't to figure out how can we help the health of individuals. How can we help the growth and development of form follows function. But by age 8, 80% of that child's growth is done. So why would I wait to age 8 to help a child's health?
That's what we're taught to do. I hate to say it.
But why are we taught that? And
that's the best question.
And then why won't orthodontists change that? And I was talking to Lucian Murrow, and he goes, Jack, follow the money. And a while ago, I said, I hate to put a dollar figure on the fact that, so if you take a guy that's been in practice 10 years, or you take a resident that now owes $600,000 and they're taking a job working somewhere. So most residents are going to get out and they're going to work for a corporation until they pay off their loan, or maybe never pay off their loan. And so that they really can't do a de novo practice like you did or like I did, and just start out with no patients in a building and overhead. And they're just not going to do that. And so they got the debt they have to pay. And so they're going to take a job. Well, I want to tell you that corporation, their concern is the bottom line. The corporation is.
Right.
I hate to say this about our organization, but the AAO, they are a very reactive organization. They're not proactive. And it seems like that the elite, I call them the elites, the elites are, and I even had somebody, I was speaking at a meeting one time, I'm not going to say it was a regional meeting, I'm not going to say where, and the guy putting on the meeting goes, man, thanks for coming to lecture, it was a great meeting. I think we made $200,000 profit off this meeting. I'm sitting there going, well, why in the heck are we charging the members to go?
Yeah.
If you're making money off of it, why do I have to pay to come to these meetings? So I'm thinking, okay, so maybe it is the money.
Yeah. I asked a past AAO president, will remain nameless. I asked that individual about why we are not teaching more about the why in our orthodontic residency programs, because the AAO has a direct influence on what is being taught in these residency programs. They do have this sort of shared space that they occupy. It's why you see a lot of program directors and chairs are very involved with the AAO and the different component societies and constituent societies and vice versa. So I said, why is the AAO not encouraging these residency programs to be more proactive, to do some of the things that you and I, meaning you, Jack, and I have been speaking about here? The answer, Jack, was because at the end of the day, Mike, the vast majority of what these kids are going to be treating when they get out is class 1 crowding and 4x extraction cases. And that's that. Yeah. That is what this individual said to me. I almost fell off my chair. I literally was taken back by it. I thought, that's the mentality. And this was not a long time ago. So I'm thinking, that's the mentality of the AAO, is that. And I said back to him, I said, well, that's interesting, because those are two things I almost never saw in my practice, because all the GPs were treating the class 1 crowding and the 4x extraction cases I wasn't hardly ever doing, because I was getting to them early and helping them grow, which is my whole point. And so I guess we're just going to have to agree to disagree. Yeah. But I think that mindset is so pervasive. So when you say being hard on the AAO, I agree. I'm pretty tough on the AAO as well. I do it out of a place of wanting this organization to be more representative. Jack, I looked, and then I want to hear your thoughts on it. I looked at this past year, so the meeting that just went on in Philadelphia, there were 168 lectures, okay? Two mentioned CBCT, and there were 3 or 4 that even said anything to do with airway related to the overall impact that an orthodontist may be able to have on it. And of those, 2 were on adults, so it was relative to adult OSA. 2 were on kids, and one of them was about basically saying how there's really nothing to it. Talk about missing the mark on this, as our pediatric dental and general dental colleagues are begging us to understand this better.
Well, if you still look at who's buying CBCTs, I have a slide I show that's got all the planets, and I label the planet like oral surgery planet, pediatric dentist planet, the general dentist planet, your implantology planet, your oral maxillofacial radiologist planet, and they're all these big nice planets. Now it's a flat picture. It says orthodontist. They still think the world's flat. And so, why is that? Okay, so if you've been in practice 20 years and you're making $500,000 a year as an orthodontist, and you're seeing 80 to 90 patients a day in your practice as a single private practitioner, and you're making a lot of money, and you're looking at your results every now and then. You're not looking at anything. Today was a D-band day for me, and I looked at every one of their final records just to see that I keep the teeth in the bone.
Yes.
That's simple. What is their airway now? Is it better?
Yep.
I can superimpose in 3D a lot faster than you can superimpose in 2D to find out. But the board still traces in 2D. It's not accurate, and you can cheat on that. You can cheat on it.
Anybody who's out there who they can't tell me with a straight face they haven't changed an angulation or an inclination a teeny bit while they're tracing a ceph. Come on, I mean it's
Well, when's the last time that you went to a lecture of somebody that was a KOL for an aligner company? And they were showing you how they closed open bites and how they straighten teeth. And I look here, they did non-extraction. And look, they'll show you pictures. And I can remember I was at a meeting, and I was sitting there, it's been 8-10 years ago, and I text Dr. Profit. I said, Prof, I'm sitting here watching these aligners, and I cannot do what they're showing. And I said, by the way, they're not showing even a post-op ceph tracing, much less a 3D or the teeth in the bone tracing. And he answered me back and laughed. He said, Jack, keep doing what you're doing, but embrace what they're doing and figure it out. Okay, so what little treatment I do with aligners, I bought my own 3D printer because I wasn't going to patronize a company that I thought was doing harm. And they never show, ever, a superimposition of a case treated with aligners for, say, an open bite and how it closed by showing the superimpositions in all 3 dimensions. And so, ever. And so why don't they? I think it's because they don't know how, probably. And if they start turning their lanterns on, they're going to see the worm. And if they start, then if they got to see the worm, now they got to go back and say, like Tweed did, and say, hey, I've done some harm. I've done harm to people. We got to stop this. And when I first started looking at CBCTs, and I knew I was doing harm, I know I was, and still do occasionally. When I see that I moved the teeth out of bone, it's embarrassing to me and my staff. They know how to look at CBCTs, and they'll go, oh, Dr. Fisher, I think you over-torqued that one. It's out of the cortex. And I go, yeah. Or look at that lower incisor you flared. Yeah. So, and today I debanded. I think we debanded 15 cases this morning. And I was going through there, and you can slice out with the CBCT. You can slice out each individual tooth and look at it. And my teeth were so centered today. I was so proud. I go, you know what? It's taken me 10 years to figure out how to keep teeth in bone. And I'm decent at moving teeth. But, as good as probably any average orthodontist. I won't say I'm that great. But the fact that I was able to look and say, man, I'm doing better. I'm getting better at this. And Dr. Ben Arsdale said the problem with orthodontists is when they finally get good, they quit. Because it's a lifetime journey. And I don't ever have intentions of retiring because it's so much fun, because I think I'm getting better. And I think I'm helping people's health. And I'm thinking we're helping them grow better.
Is that what you attribute the better results to? Is that you're helping them grow better earlier, so you don't need to be trying to fit these crooked, crowded teeth to these bones that are not meant to line up with one another?
And I'm going to give you credit for something. I had a dental student that just graduated, and I saw a picture of their Labor Day weekend. He had all his nephews and nieces who were like 4, 5, 6 years old, and I'm looking at their teeth. Oh my God! And I've been around these kids. Why haven't I said something to them? I said, you got to get your niece and nephew out here to the office ASAP. He goes, well, why don't we just wait till they're 12 and 13? That's what they taught us in dental school. And I go, come on, you ended up with 4 buys out. Yeah, I did. And I go, well, luckily I didn't treat him, but anyway, he goes, oh, you think we can avoid that? And I go, maybe. So he texted me today and goes, well, when do you expand them and how? When you put the expander in? I said, look, I don't always put an expander in. I learned from Dr. DeLuke that maybe we could put braces on and expand them with the wires and let their tongue expand the maxilla, like the brain expands the cranium. Because the tongue is the strongest muscle in the body. And to tell me that it won't mold the maxilla at age 3, 4, 5, and 6 is just denying anatomy and research. So which brings up a whole other topic I want to talk about is the whole that they will say, well, show me the evidence.
You beat me to it. I was literally, go for it. Go.
Well, evidence is the 3 circles. Okay,
Yep.
how much experience does the clinician have?
Yep.
What are that patient's needs? What are the diagnoses? And
Yep.
I will have people say, well, I had today on the internet, I was looking at Facebook, and my mother says, but I don't want MARPI. Well, I wouldn't want it either. But I didn't want orthodontic surgery, but had it. Yeah, and now I've got 4 implants because I had a 3-piece maxilla, which I shouldn't have ever had to had. And now I've got 4 implants because he hit the roots when he did a 3-piece maxilla. And I'm a dental cripple because of the way I was treated orthodontic. But so I told him, I said, so maybe we don't put expander in, maybe we put braces on. He said, and let them expand their own jaw. So it just depends on the parents. It depends on their needs. It depends on the anatomy we see in the CBCT, and it depends on my experience. And, I think maybe 700 MARPIs I've done. That's quite a bit of experience, And so,
I'd say.
so yeah, I've seen the results of that, and I've expanded. Starting now, I can't say thousands like you do, but I can say hundreds of kids, little kids, and seeing the results of what they're doing now. And it comes time for braces, and they don't need them. And because of you, I've started putting braces on them.
Thanks.
And they go, I just don't want that expander in there. And I got to turn it every month. I said, no problem. Let's put braces on them. And I think that works just as good.
It's amazing. If you get them young, it's amazing.
But if you catch them at age 8, and they're starting to lose some of their primary teeth, and you're going, I got to get in there and expand now. So I put an expander in just to get them done. Dr. Prophet always told me, he said, don't ever do RP, a rapid palatal expander, on a little kid.
Thank you. And that's in his textbook. I quote that when I lecture a lot of times. That is in contemporary orthodontics, that all the people turning these screws rapidly, applying 3 to 10 pounds of force per turn on these young skulls. Prophet said under the age of 10 that it can be dangerous and cause the face to disfigure. I mean, he literally says that, but we don't. So thank you for bringing that up.
Of course, the vomer bone, which attaches to the pterygoid bone, and it can drop. So if you expand them too fast, too young, and I understand that it's not fused, that the vomer bone is not fused yet, and but it's got a lot of fascia on it. So I talked to an ENT about that. He goes, I just don't believe it could ever drop. And he goes, well, I'm not going to be the first one that drops on, I'll tell you that. and I just think more really, really, really slow expansion. And I don't even think MARPIs, when I first started doing MARPIs, we were turning them 2 times a day. And, Audrey's got me, she goes, look, on your MARPIs, you turn them 1 time a week. Okay, 1 time a day till they separate as an adult. But if it takes more than 10 turns, you better stop. But as soon as they separate, you can turn it 1 time a week. That's it. And then by the time you get through turning, you can pretty well take it out because the bone is already filled in because you did distraction osteogenesis. But anyway, that's a whole different. I didn't mean to get sidelines on MARPI, but
no, that's okay. That you had gone through the 2 circles, the clinical expertise, the patient, and then the third one being
the research. Here's what I'll tell you about research. This is Einstein. It's not with me. Albert Einstein said, what is always counted in a research project doesn't necessarily always count. But what should be counted is not always counted. And if you did research on me, I would have been an outlier. Okay, you were treated okay. You don't have any results of that. And so we'll do a research project on a 14-year-old, and we'll say taking out 4 buys did not cause obstructive sleep apnea. I used to dunk a basketball really good. I can't anymore. Why is that? Because it's when we age, our whole neuromuscular sympathetic, parasympathetic starts deteriorating, changing, and your muscles relax and change. A little kid is able to adapt, just like I was able to adapt and become a dentist because of dyslexic and ADD. I had the ability to adapt. I don't think I could adapt even that now as you age. So you're not going to see obstructive sleep apnea. Even Christian Minot said, OS, he's the one who came up with obstructive sleep apnea. He said that was the worst thing I ever did, is to do that, because kids are not going to be diagnosed with obstructive sleep apnea. At our winter meeting last year, one of the speakers was a sleep physician from Pennsylvania, and she goes, you can't, widen the palate does not prevent obstruction. It does not cause obstruction. And I'm sitting there, okay. I mean, I can't tell you how many children I have sent for sleep studies. Realize now I don't.
Right.
There's no sense in sending a kid for a sleep study.
Yeah, and the ENTs will tell you that all day. As will the sleep physicians. Yeah.
So you got to realize that airway disease is a very progressive, debilitating disease. Mm-hmm. Just like cardiovascular disease, it's very slow developing, and also age 50 die of a heart attack. And so I think the way we have treated children, let's say a kid that's got 4 degrees A and B difference, and they got 6 or 7, maybe 8 millimeters of crowding in the upper arch and the lower arches, a little, it's crowded. And, in years past, I'd go, that's 4 bicuspid extraction case. Mm-hmm. And that child had normal sized teeth, but deformed jaws.
Right.
Why would I take out something that's normal to fit something that's abnormal? To me, that's just a common sense answer. When was the last time you had a case that had beautiful jaws, huge teeth that were crowded, class 1, and you took out 4 bis? You just don't see them.
Right. It's almost unheard of. Literally.
It's always they've got small jaws and normal teeth. I get the fact in my demographics that in Memphis we do get a lot of children that lost early teeth because of sugar and candy, and they lost the east base. Now they're crowded. I get that. That's a total different story.
Agreed. Yep.
But we're causing smaller jaws. So the way we treated cases, and the board just about 3 journals ago had a case that they showed 2D Ceph models, and they took out 4 bis. It looked beautiful. Mm-hmm. And I'm looking, I wonder how wide that arch is. I wish I could see a CBCT. When I work up a patient, the first analysis I do is the coronal. Mm-hmm. I don't look at a Ceph hardly. I mean, because I can't change the mandible. I mean, and Prophet even told me one time, he said, Jack, you look at Cephs? And I go, well, I wanted to say, well, of course, Dr. Prophet, we trace our Cephs. He goes, BS. He said, you can take a film and hold it up and say, well, that's a class 2 patient. That's a class 3 patient. Why do you need all those numbers? Mm-hmm. He said, you got to start looking at the transverse.
Yeah, Prophet said that. Interesting. Yeah.
You got to look at the transverse, son. Okay.
And Jack, how do you do that without a 3D? I mean, you have a PA, obviously. Not many of our colleagues are taking a PA Ceph, but without 3D, how do you get that coronal view of your patient?
I mean, you can't. And the residents, they're not even taught what the norms are.
Right.
And I'm not sure we know what the norms, and every patient may have a different norm. But I know I'll tell you who's got one of the best residency programs in the country. It's Dr. Tremont in South Carolina.
I'm not familiar with that. Okay.
If you had not asked him to come on, you should. He just published an article that's really good on transverse.
Okay.
And I'm sort of proud. This sounds weird. He never mentioned in the entire article about airway, but his total article is on transverse.
Yeah. Which is great, because I think the two get conflated a lot of times. Yeah. And I always say to people, I just had this discussion. It was actually in a text thread with some colleagues. And I literally said to them, and we all have a similar mindset as similar to what you and I have on normalizing anatomy. I said, I really feel that we have to get away from this. We're doing this to treat airway concept. I feel we need to focus more on, we're doing this to normalize anatomy and develop the appropriate size jaws to accommodate the teeth at a younger age. And when you do that, this patient will also have more tongue space, broader palate, palatal vault that's not as high, which, being that superior to the palatal vault is the nasal floor, they'll have broader nasal anatomy. They'll have greater tendency to nasal breathe. They won't be mouth breathing, which causes the inflammation of the lymphoid tissue, adenoids and tonsils. It's all connected. And I agree with you. I think by just saying we're treating airway, we're not treating airway. We're treating the patient. And when you treat the patient and normalize that structure, yes, they breathe better a lot of the times. So I'm glad you made that point, because I think that's it's something we're doing to our detriment. I feel, those of us who do believe that we need to be more proactive on this. Airway is a side benefit of this. We need to discuss it, but it's a side benefit. So
people will ask me, "Were you an airway orthodontist?" And my response is, "What is that?"
Right.
What do you mean by that? What are you saying I might be? What does that mean that you're an airway? I said, I know that when you're born, you're not alive till you take a breath. And when you die, you quit breathing. I go, breathing and oxygen must be pretty important. And babies are nasal obligatory breathe. They have to breathe through their nose.
Yep.
But then as they start developing, they become mouth breathers. So why is that? So why can't we keep them breathing through their nose?
Right.
And so the white paper, everybody wants to call it the white paper. I went to that meeting and sat there 18 hours when they did that meeting. It was a great meeting. It was a winter meeting, and it was on your side.
Down by me in 19. Yeah.
In 2019. I went down there and I sat next to an oral maxillofacial radiologist. And the whole time, and Christian Minola also spoke there. One of the times he spoke before he died. And I walked out of that meeting going, wow, I learned so much. And I go, it looks to me like it's all about nasal breathing. Mm-hmm. But then a lot of people walked out there saying, see, we don't have anything to do with it. And I'm going, that's not what I got out of the meeting. And then they came out with the white paper, and I didn't see that much damaging about the white paper. And the very last of the white paper, it says every dentist, pediatric dentist, orthodontist should evaluate their patients for nasal breathing. Why? So it must be important. And so you know how long it takes to evaluate a kid for nasal breathing in your office?
Yeah, it's always been a frustration for me that the white paper didn't talk about, and the AAO still doesn't talk about. It's a lot of what I teach about, how to do it. It literally says in the white paper, as you said, we should be screening every single patient for airway compromise. We're not teaching it in residencies. I've tried to implement it at Nova, and it was not well received. So they don't want to teach this because of the time and energy it takes, because it's a paradigm shift from a mentality standpoint. But no one's giving guidance. So they throw this out there and say, yeah, you should be looking for this. They don't tell you how. Did you happen to see the articles I had in Orthotown that just came out? So those, I'm trying to get out a little bit of the information just to say, like, this is how you start to go down this path, because it's not challenging to do once you know how to do it. But if you don't know how to do it, you don't know where to begin, right? I mean, where do you even start with this?
Yeah. I mean, so a lot of people say, well, how can I get involved with this? I mean, 2 steps forward, 1 step backwards. 2 steps forward, 1 step backwards. And it's a learning process. And I've read Stupak's book. I've read probably 3 textbooks. Continue to read articles. Audrey Yoon's stuff. You have to keep reading and learning and learning. And so we invest a lot of money in Sleep, Breathe, and Thrive, A Brave Parent. And we give those books out like popcorn to our patients, because, it takes a long time to educate a parent. And I'll tell them, they'll come in and I say, well, we heard that maybe you can help my child. They're snoring at night and this and that. I go, look, I'll talk, I don't ever look at their teeth. Their teeth is the last thing I'm going to look at. I'm going to sit and watch the kid. I'm going to talk to them. What's your home life like? You can try to if you get to know your patient. And we know how to fix teeth. Come on. I'm not going to look in their mouth and say, oh, it's class 2 molar. I could care less how they end up class 2. Class 1, I want them to end up healthy, and so smile in the vibrant light. And so I'll give them the books to read. I let the book educate. If they don't, I say, by the way, if you don't take the time to read the book, I don't think you would be fit into my practice.
Interesting.
You read, because if I accepted all of those families in, I mean, they're very time consuming. Or they're a lot of fun because you get to know your patients. I love doing consults. And so we do our diagnosis a bunch of steps. We just don't try to sit down, because I asked the chairman of a program, I go, well, are you all doing the white paper, what they recommend? Oh, yeah. Well, we put the check marks in. I think we have a form that talks about tongue ties. I go, a form that says tongue ties. I said, how do you evaluate that? Because I just recently learned really how to evaluate it from Dr. Zaghi in his lecture. I attended a pedo meeting. I'm not a pedodontist, but best meeting I ever attended. And Dr. Zaghi spoke. Audrey Yoon spoke, and they said, how many of you pediatric dentists have CBCTs? Out of probably 400 people there, probably 200 or 300 of them raised their hands.
Was it really almost half the group?
Oh,
wow.
Yeah. Oh, yeah. We sit at the table. John Price and I were probably the only 2 orthodontists there. It was in Atlanta, the Southern meeting. And so they get it. They're starting to get it.
And they're going to get it right over the top of us if we don't figure it out. Like you said, we're on our way to Blockbuster if we don't wake up.
I learned from, I hate to mention somebody's name, but he's the richest person in the world. We'll just say that. Okay. and he goes, somebody was interviewing him because he's been on TV a lot lately. And somebody said, well, how do you know who to hire? How do you know? He goes, well, I look at 2 things. That's all I look at. I want to know, are they competent and do they care? And I got to think about that. And I go, you know what? The Bible says I don't know my own heart, much less yours. And so if I'm looking at somebody or I'm looking at a patient or I'm talking to another orthodontist or to a resident, and I can't judge if they care or not. I really can't. At the ABO, do they care? I hope so. I can't judge that. And the more I thought about it, the more I'm thinking he's right. The two are very conflicted together because if you don't care, you're not going to become competent. So you have to have a reason that you care before you're going to go spend $100,000 on CBCT. And then you're going to spend nights and days and hours learning how to manipulate, how to look at that. I'm going to tell you, if you're going to do MARPE, and you don't have any bone, you got to hit the Y from the nose, the maxilla, and the floor of the nasal. You got to hit that. You better know how to read it. You better know how to do that. And you just don't. You just don't know that when you go buy one. It's going to take you years to get there. I'm a slow learner, so it's taking me years to get to that point. And so, okay, am I competent? No, not yet, but every day I think I'm getting better. And is it because I care? Well, I hope it's because I care. It's surely not the money, because it's not really profitable to start out treating those young kids like that. Because you hear people on the internet, they go, you know, you're doing it just for the money on those expanders. And I go, really? Okay. You think you know how much it costs for a MARPE appliance to get a good one, $1,200? Yeah. And from a company that's doing those. And so
I've said for a long time, Jack, if people knew how to monetize phase one more effectively, there'd be a lot more orthodontists doing phase one.
Lou Shimura, I was talking to Lou about that very topic. He goes, Jack, look at the money. It's very costly to do that. But the only reason you would do it is maybe it's because you care, okay. And so that whole thing about being competent and caring. And so I got in trouble at the residency program. And I made the statement, and I think this was too strong to say, but I'll go ahead and say it to you and your audience. I think it's immoral for me to take a resident and have them in their department 3 years, and they walk away from there knowing how to move teeth, but they don't know how to walk away from there on how to help somebody's health or how to keep teeth in bone. I think it's immoral, and you got to think, well, maybe somewhere down the road people don't care. And so then the chairmen will say, well, Jack, that's the standard of care. I have to teach the standard of care that the board says.
Have we been in the same room together, Jack?
Mike, our country is a revolutionary country.
Thank you.
We were founded on revolution, not a monarchy.
Yep.
And so I said, so you're telling me I have to teach the residents based on a monarchy that some group of men and maybe one woman says that's the standard of care.
Right.
So I was working on my airplane the other day, and a thoracic surgeon walked in. He's retired at age 62. He did 500 heart transplants.
Wow.
And I said, hey, dude, when you finished your career, were you doing those surgeries like you did 20 years ago? And he goes, no, of course not. The technology evolved.
Right.
And I'm going, when did the standards of care come about in orthodontics? 1952.
I was going to say mid-50s. You got it. Yep.
73 years ago.
Yep.
That's when they came out with the measurements, upper 1 to SN.
Yep.
Why do I care what the upper inside is? As long as it's centered in the bone, or if I am going to move it out of bone, I'm going to add some bone.
Yep.
Okay, that's a whole different topic. But anyway, so what specialty out there anywhere is delivering the same standard of care that was established in 1952? And I asked Mariana.
And using the same diagnostic parameters, Jack.
Yeah. I asked Mariana Evans that. I said, Mariana, do we even know that if those measurements on the lateral set are accurate, if they had a normal coronal width and normal time? Do we even know if those? She goes, no. She goes, I can tell you they're not accurate.
Yeah.
So not only are they probably not accurate, the study has never been done. So don't say I'm not evidence-based.
And that's, I'm so glad that you explained it that way, because as you said, and just to underscore that part too, you said so many awesome things that racing through my mind here to try to highlight a couple of them for the audience. The evidence basis concept of it being those three circles that you explained, where those three overlap in the Venn diagram. So the clinical experience and expertise, the patient values and preferences, and the research, which, newsflash, does not have to be a randomized control trial or systematic review. Yes, that is sort of the quote unquote best research. But when Sackett developed the concept of evidence-based medicine, he specifically said it does not have to have a randomized controlled trial. It can be a goal, an honorable goal, but not necessary. But where those three overlap, that intersection is evidence-based practice. So I ask people all the time, people who are in high positions within academic programs, are those circles the same size? And you know what, Jack? I've yet to have one of them give me an answer. They actually act like they don't know what I'm even saying. And I have said, like, if you have three circles, we agree there's three circles, right? Because that's indisputable based on what the definition and the foundation of evidence-based practice is. Are they all equal, or are the patient values weighted more heavily than my experience, et cetera? And they don't want to say it because that means that our clinical expertise, and Sackett says this, if the studies aren't there to justify a specific treatment approach, then you go to the next available evidence, which can be the clinical experience and expertise. That you are not required to wait around for a long-term randomized controlled trial to be conducted or enough studies to be done to run a systematic review to withhold care from this patient that you know could be beneficial. So I want everyone to hear that and keep saying that over and over again to everybody in academia who likes to clutch their pearls to this evidence-based medicine concept, and within that, this randomized controlled trial gold standard, right? It is completely and totally a fallacy. And the last thing I'll say is, a gentleman wrote an article, I've mentioned this on the show before, but a gentleman who was a friend of Sackett. Sackett died in 2015. It was in 2016 that an article was written. How do you say his last name? It's John Ioannidis. John Ioannidis. And he basically, it was called The Evidence-Based Medicine Has Been Hijacked, a report to David Sackett. Yeah. And it's essentially talking about the fact that people with ulterior motives have used this evidence-based concept to advance their agenda. And I guess I want to finish it up by saying, so what do we do about it? You right? Sum that up in 30 seconds. Like, no, but take a couple minutes if you would, and just to end it on a positive note for our audience of what can we do to start to shift this paradigm?
You have to educate the public. I want to tell you, there's a people are more motivated, Michael, by what they may lose than by what they may gain. And orthodontists as a specialty, maybe the ABO, maybe the AAO, they need to realize what they're going to lose. Because once they realize the blockbusters may be going out, then maybe we should have bought Netflix. And I spend most of my time, when I'm talking to somebody about that, I'll say, keep doing what you're doing, because over a long haul, it's going to be bad for you. You're going to lose out. What do you mean I'm going to lose out? Now you've got their attention. Talk to them. So I think you have to motivate those big organizations like that. One more quick story. Zig Ziglar used to tell this story.
He's great, yeah.
Zig Ziglar had a story, and grandma, she cooked Thanksgiving dinner every year, and she would take a ham and cook a ham, and she couldn't come this year because she was in bad health. She's getting older. All the nieces and nephews, and they all got together and said, I got the ham. Let's cook it like grandmother did. And what do we do first? They go, well, you cut the end of the ham off, put it in the water, start boiling. They did all that, and it tasted pretty good. And they called grandma and said, why'd you cut the end of the ham off? And she goes, you all are so stupid. It wouldn't fit in my pot. and so,
yep.
It's like that. It's like some of our organizations are, why did you do that in 1952? And why do we still do that? Well, it wouldn't fit in the pot.
Yeah.
So it's the only way we can get the teeth into the arch, because we couldn't broaden the arch.
Right.
But now we have the technology to not only diagnose it, but now we have the technology that just came about in the past year or so to print those appliances, to put those screws exactly at this, and to widen the anatomy of an adult without doing SARPI. And I'll tell you, I'm going through the process as we speak today of getting the medical code for doing MARPI. There's not one. There needs to be one. So if you send a patient for a SARPI, the surgeon's fee is not very much. He gets like $1,000 for a SARPI, and he's got a patient in the hospital that's asleep. The total fee the insurance company will pay will be $20,000 for a SARPI that's not very effective anymore. And you can be much more effective with a MARPI. And yeah, okay, I'll charge the patient $5,000 for the MARPI. Is that better than $20,000 the insurance company code? So I'm beginning to file those on a medical code, and I can do that in Tennessee. Yeah, I have to get approved to be a medical, to file it on medical. Or surgeon, but why is Dr. Fisher certified to do that? Well, he's doing a skeletal procedure. It's not an orthodontic procedure.
Yeah, that's so great.
And so, so we're starting to do that, and I think we should be paid if we have the experience, and if we do have a evidence-based practice where we've done 500 or 600, 700 of those, and we sit down and talk to our patients, and we do read the research, and so if I am evidence-based, we should be paid for it. Yeah. We all do our free work.
Yeah, and I love that because I've said for a while, I feel we need to find a way to get early treatment reimbursed, which is where we need the AAO and the ADA to get. They just recently cut down the codes for early treatment a couple of years back to make it fewer codes and more constricted on what we can bill for under insurance on phase 1 interceptive treatment. So we need to get the Saltzman index. That was 68, right? Which is the barometer for a quote unquote handicapping malocclusion that we use in residencies and for any of patients of the underserved populations. That's part of the reason why we don't learn this in school, is because the residents are in a lot of times schools which treat high percentages of patients in the underserved populations, and they can't afford private pay care. So the state is paying for them, and the state criteria are set so that they can't go in those patients where you were saying you see the coronal slice, you see the transverse deficiency, but they don't have a posterior crossbite. They're not going to let you develop those arches and grow that patient. They're going to say, wait until the teeth come in, pull them, and straighten them. So I feel we need to find ways to get on the political side, and maybe now with RFKJ in there and this sort of push towards more proactive care, we can start to, I've been saying for a while, I'd love to get on Huberman and be like, we need to waken the politicians up to just understand. But I really feel, Jack, and I'll let you close it with this thought. I'd love to hear your thoughts on it. I feel that if you and I alone can't do that, even all the people we know, until the AAO and the ADA and our residency programs get behind that concept, that's going to be a very, very tough sell on a broader scale.
Well, interesting you mentioned the ADA because they seem to be behind it.
Oh, agreed. Agreed.
The ADA, you take Dr. Boyd in Chicago and some of those people, the ADA is a very proponent of early treatment.
I agree. And the coding, they don't have the coding.
That's right.
Because they're turning to the AAO and trusting what the AAO Insurance Council says for the ADA. So I don't mean to point any fingers at the ADA. They've been awesome.
They've been
and Steve Carstensen, what a blessing with his 2017 position statement that he helped write. Actually, just was referencing on our previous show, we were talking about it, but it's such a great asset to our profession as a whole. But they turn to the AAO and to the orthodontic training programs for guidance on this stuff, and they're not getting any. Yeah,
I just got his book. I'm reading it. But anyway, you're asking me what's the solution, and I don't have that solution. I'm not that smart of a person. But I do know that I've got to do what's right for my patients and educate the public. And the more the public's educated, the specialty will see what they're losing. And I'm motivated by what I might lose. I mean, what little retirement I have filed, I don't want to lose that. I'm more motivated to keep it than I am to maybe walk out on a limb and get more. And so I think that we just, what you're doing is probably one of the few people I know that are fighting the fight every week. And I know you diversify it out. 1 week you'll do financing and some other things, but then you're right back on. I was listening to the one you just put out today before we logged on. It's really good. And so
the Dave McCarty one, he's great.
He's great. Yeah. And so anyway, I think hope you keep doing what you're doing and keep fighting the good fight because you've got the skill set to do that. And I have not treated thousands of young kids like you did, and you were a pioneer in that realm, no question. And so we need Lou and I were talking, we need a study to bracket these children up compared to a more of a mechanical expander in their palate, that they can't get their tongue on the roof of the mouth, even with that in there. But anyway, so.
Well, I've got the data. Even I appreciate the kind words very much.
Yeah,
and even from a retrospective standpoint, to start analyzing thousands of pre and post cone beams on these kids.
Yeah.
And I agree. Once we start to get the public educated, but what you're doing too, I want to make sure that you get the credit you deserve for that, because you don't have to be, after practicing for for 35, 40 years
well, 83. I started in 1983.
Yeah. So, yeah. You don't need to be fighting this hard. And we owe you a debt of gratitude for always being an innovator, a thinker. And one of the most fun parts about what I'm doing now is I get to meet people such as yourself, interact with them. And it really does fuel my fire, because I see other colleagues that are like-minded and want what's best for these patients and for our profession and are willing to fight for it. So I promise I will keep fighting that fight as long as I am willing. As long as I'm able, I will be willing. I can promise you that.
Well, keep at it. And I'm very humbled that you was asked to maybe participate in this hour and a half. So thank you very much.
Well, I'm humbled at your kind words and at your willingness to come on and being excited to come on the show. It means a lot to me, and sharing so openly. This was a really, really fun discussion. I really enjoyed quite a bit, and I appreciate your openness and honesty and not playing it safe, but being willing to put it out there. And it just made for an awesome conversation that I know is going to help a lot of young docs, especially who reach out to me and they're just not sure about all this. So hearing your wisdom and your thoughts, I really want to acknowledge you for your ability to share that and your examples. I love your stories and your examples too. It makes it much more understandable. So well, thank you so much, Dr. Jack Fisher. Anything that people can reach you if they're interested in getting in touch with you, or anything you're doing that you want to let people know about?
Yeah, my email's jack.fisher@mac.com. Okay. And so they're welcome, reach out, call me or anytime. So, I love talking. Obviously, I love talking about this and helping. I love education. I'm very passionate about education. But anyway.
It shows. It shows very much. Well, keep it up, please, and stay in touch. Let's stay in touch on this, and we'll keep fighting this together.
Okay.
All right, Jack.
Yes, sir. Later.
Appreciate you.
Yes, sir.
Bye. Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses, or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the Doc community on Facebook for more great content. Thanks so much for listening, and always remember, you have been blessed with the ability to do amazing things.